Welcome, everyone. We're going to give another minute or two to let people join before we get started today. But thank you for joining us today for the OMS Family Planning Alternative Payment Model Public Rate Forum. Jessica, just let me know when you feel like there aren't many people joining, when we feel like we've gotten everyone.
Okay.
Thank you.
I think you're all set to start, and then as people join, I will just keep letting them in.
Thank you. Well, welcome everyone. This is the MaineCare's Family Planning Alternative Payment Model Public Rate Forum, where we'll be reviewing the model that we've been building with your participation over the last year. We appreciate your participation and we appreciate you being present at this meeting today. And I'm going to turn it over to Michelle for a welcome. To Michelle Probert, our MaineCare Director.
Hi, everyone. Michelle Probert. I use she, her pronouns, MaineCare Director. As Heather said, thank you for being here this afternoon. I will be very brief. I'll just say that it's been exciting to watch this model and proposal evolve, and we're excited to share it with you today to be able to provide more, I'll call it wraparound support for the critical services that you provide, and also to provide an opportunity to be reimbursed for quality performance as well. So look forward to your participation today and your input, and I will turn it to the team. Thanks.
Great. Thanks so much, Michelle. I'm happy to jump in and walk us through the agenda. Hi, everyone. I've had a chance to meet with most of you previously. My name is Avi Herring. I'm a director with Manat, and I've had the opportunity to work with the MaineCare team and with many of you over the past year in developing this model and incorporating your feedback and really being able to hear about your experiences in providing care and such important care that you provide to Medicaid beneficiaries. So looking forward to walking through the proposal today for your feedback. The first thing that we're going to do is spend some time giving an overview of the model, broadly walking through sort of how the different pieces fit together, the rationale for why we've developed the model as we have. Then we're going to spend some time really doing more of a deep dive into the different components of the model, and then looking at a sort of estimated financial analysis of the alternative payment model. And then we'll spend some time on comments and questions. So that's the plan for today, and really looking forward to having this discussion with you. Let me turn it over to Jessica to walk through the Chapter 639 rate determination process overview as well.
Thank you, Avi. Hi, everyone. I'm Jessica Levesque. I'm the project manager from the Rate Reform Unit. I want to remind everyone that we are recording this presentation, and we will be saving it on the website for your access at a later time. I'm going to be going over the new Public Law 2021, Chapter 639, the rate determination process. This law was effective in August of 2022, and it establishes a process for the rate determination, which so soon I won't be able to say this is a new law because it's 2022, but for now, it's still a new law. What this new law does is it provides, sets a schedule for a regular rate review and adjustment. The schedule for how often the rates are reviewed depends on if it's benchmarked from Medicare and other payers, or if it's a non-benchmark rate. Also, this new law ensures review of relevant state and national data to inform rate amounts and payment models. Reimbursement can be connected to performance. Also, this law formalizes a clear and transparent process for rate determination. So what that includes is the stakeholder engagement, so public presentations of draft rates and having public engagement. an opportunity for you to provide written comments. The department also responds to the written comments, and they are posted on our website. And we established a Maine Care Advisory Committee, which we refer to as the MAC, and also establishes a technical advisory panel, which we call the TAB. At this time, I just wanted to let everybody know that as we get into the presentation, we're going to ask everyone to please save questions and comments to the end, where we have allowed time for those questions and comments to be answered. In the meantime, if you wanted to type a question or comment in the chat as it comes to you, we will get to those at the time when we answer comments and questions. I'll read them out loud, or you can wait and raise your hand. And I will hand it back to Avi.
Great. Thanks so much, Jessica. All right, so we're going to move through here and start giving a sort of broad overview of the proposed APM model. The tentative name, sorry, so to zoom out a little bit, what we wanted to do first was to reorient the group here to our shared priorities and goals. And these are goals that we have talked about over the last year together, and I think are really still relevant today. So the first is really thinking about the role that family planning providers play and the services that they provide in the community. One of the things that we've tried to do here in the model, and I hope you'll see really that we've tried to weave this in throughout, is recognizing the really unique and the essential role that family planning providers play in Maine's healthcare delivery system, including a really important focus on outreach, engagement, and care navigation. And we want to make sure, and I think you'll see in this model, that has really been incorporated and accounted for in both the set of care delivery requirements and the proposed reimbursement approach. The second thing that we're really aligned on is thinking about alternative payment model design, that we want to make sure that this APM provides an appropriate level of reimbursement for both service delivery, for the reimbursement for the care navigation activities that you provide, and also that there is a connection between payment and quality. We also want this model to be simple, and we want it to be sustainable, so that the sort of different components combined are able to really produce what is a sustainable reimbursement model that you can depend on going forward to care for Medicaid, to care for Maine Care members. And then finally, as we think about quality measurement, to really focus on a set of quality measures that both meaningfully assess family planning provider performance, and also really importantly, aren't stigmatizing to the population seeking care. So those really have been touchstones for us from the beginning in working with you. And we try to incorporate those components into really all portions of the APM design. Before I keep going, let me just turn it over to Olivia. Olivia, if you want to just add any additional context before we start to walk through the components of the model.
Sure. Well, I think you did a great job, and I also, I missed a chunk of time when you all were going back and forth. I should say you all. There could be other folks on the phone that didn't participate in that, but essentially, I know there's been back and forth with family planning agencies and providers around the development of this model, and so that's great. I love to see that, and I think we're going to touch on the points that have been salient throughout that back and forth today. And then I just wanted to say at a broad level, Maine Care, we absolutely approach this thinking about the investment that we currently make in family planning agency services, and thinking about how we want an alternative payment model that we're designing here to reflect an understanding of the status quo, but also want to touch on the benefits of having an alternative payment model, which include stability of payments, flexibility of payments, and a tie to quality. So, there's differences when you transition to an alternative payment model that have inherent benefits. There are inherent differences within that kind of approach as well. So we have taken all of that into account in presenting what we have for today, and look forward to continuing the conversation after today.
Great. Thanks, Olivia. Okay, so now we're going to start going into more detail around the components of the model. We'll first share an overview and then really get into the details of each component. So as you've seen before, what we're envisioning here is an APM with 3 different building blocks. The first would be a care navigation per member per month payment paid to family planning providers to support your outreach and engagement and care navigation activities. The second would be tying core Section 30 fee schedule rates to 100% of Medicare. And then the third would be establishing a quality enhancement that would be over and above the sort of base fee schedule. To get a little bit more detailed on the care navigation PMPM, what we're proposing here, again, is that this would be paid for every member that is attributed. I know that there have been a lot of questions around how the attribution will work, and we're going to go into more detail on that in a little bit. What I do want to be really clear about as a starting point is that while the attribution will be sort of similar in methodology to primary care plus, the focus will be, the attribution driver will be Section 30 claims, not primary care claims. And I know that that was a big question in some of the feedback that came to us over the last couple of months. We're going to go into more detail, but that's a sort of going to be a critical difference in methodologies. The second component, then, like I said, is this enhanced fee schedule. So a core set of Section 30 family planning services that have a Medicare benchmark will be set at 100% of Medicare. Those will be aligned with the payment rate for non-hospital-based primary care services. And just to kind of give you a sense, when we talk about core set of Section 30 family planning visit services, when we went and looked back at 2022 utilization data, about 90% of Section 30 billed claims with a Medicare benchmark would be paid at 100% of Medicare. So we're talking about the significant majority of claims that are paid. And then finally, there would be what we're calling here a fee schedule quality enhancement. So there would be a percentage increase to Section 30 services, specifically those that are eligible for the 90% family planning FMAP based on quality performance. And that would be layered on top of the fee schedule where most of those codes would be paid at 100% of Medicare. What you'll see on the right-hand side of the slide here is just a visual depiction of what I just walked through. Those are the 3 building blocks. And I recognize, related to any APM, the devil's in the details. And so we want to make sure that we spend a lot of time today walking you through how the different components of these rates, how we're proposing to build them up, and to really make sure that there's an understanding and that you're able to share feedback on each piece. Okay. I want to spend a little time talking about the rationale for why we're structuring this proposed APM the way that we are. We've talked about this in the past, but want to make sure that we're focusing on a couple of key points here. So the first is, what we heard in really consistent feedback from family planning providers over the last year is that you are currently delivering a set of really critical services that are not reimbursed, especially related to the wide array of care navigation and care coordination activities. And what we want to make sure is in this new APM that there's an opportunity for you to receive reimbursement for those really important services that you're providing to members in the community. The second piece, and a really important goal here, is to ensure that you have a stable, family planning providers have a stable source of funds for those ongoing care navigation activities, regardless of the monthly changes in utilization that may occur. So what you can see on the right-hand side here is just looking at total encounters by family planning provider by month over the past 4 years or so. And what you can see here, even just putting the COVID impact aside, what you can see here is that there is really significant variability in that monthly service utilization. And so what ends up happening is, based on the current methodology where there's this 225% add-on for a subset of services, as utilization shifts, if it goes up or it goes down, that can have a significant impact to your reimbursement month over month. What we're proposing here is to pay now a significant portion of reimbursement through this per member per month payment, which, like I said before, will both reimburse, more appropriately for the activities that you're providing, but will also create more financial stability, right? Because those payments will continue to come on a per member per month basis, regardless of the specific set of services that are being delivered. So that's an important point that we wanted to focus on and to really make sure that we're communicating clearly today. The third item here is wanting to make sure, like Olivia noted earlier on, that we are tying the delivery of high quality services to payment. And so that's why, as I talked through a little while ago, and as we're going to go into more detail in a bit, the third building block of this model is focused on a link to quality. And then finally, what we've tried to do is, where logical, to align the family planning APM with the primary care plus care navigation approach, but with differences, and you'll see where they are. We want to spend time on that too, with differences where it makes sense, right? Where there are differences in the kind of care that you're delivering to MaineCare members. We want to make sure that the care navigation and the care coordination that family planning providers and that primary care providers are delivering are complementary, but are also appropriately tailored to the needs of members that are coming through your doors, either physically or virtually. And so we've really tried to both incorporate that in our work and to also incorporate the feedback that we've received from you in making sure that we're accounting for those differences. So that's generally the rationale that we wanted to walk through. I also just wanted to give a quick update on the stakeholder engagement that we've really had an opportunity to do so far, and where we've really had an opportunity to learn from many of the folks on this call. So over the past 6 months, back in May, we had a stakeholder engagement meeting where we presented a much higher level version of this APM and got some initial feedback. Then we had a set of back and forth with providers around the specific proposed requirements that is part of this APM, and we were able to both solicit and then incorporate feedback on those requirements. After that, we conducted a provider survey that gathered more information to inform the development of the APM rates that we're going to walk through today. And then, like I just noted, we've had an opportunity to revise the provider requirements and the rate model based on the additional feedback that we've gotten from you. In terms of stakeholder engagement going forward, we're going to reserve 30 minutes of today's meeting for an open discussion where we invite feedback on everything from the kind of rationale, higher level questions, to much more detailed nuts and bolts questions around the rate development. And then there will be a 2-week public comment period following today's meeting where you can provide written feedback. Before I keep going, on the OMS team, anything, Jessica, Olivia, Heather, Michelle, that you wanted to add there? I'm seeing mostly no. Okay.
No.
Great. All right. Okay, so now we're going to start going through more detail around each building block of the model. The first piece, and I know where there have been lots of questions and there's a lot of interest, is on the care navigation PMPM model, both the provider requirements and then the rate buildup. I'm going to walk through the first part of this, then I'm going to turn it over to Maria Dominiak, who's on the call and who's an actuary who's partnered with us throughout this process, to walk through more specifics around the rate development. Okay, so first of all, let's just talk about provider eligibility. So what we're proposing here is that to be eligible for the model, providers will need to do the following. The first will need to be enrolled in Section 30 of MaineCare policy. Second of all, would need to generate at least 35% of their Medicaid revenue from the delivery of family planning services. So not family planning related services, but a specific set of codes defined as family planning services. And third, would need to meet the provider requirements that will be set out as part of this model. So those would be the three criteria in order to participate in the model. In terms of the provider requirements, like I've noted earlier, the FP provider practices will receive a PMPM payment for all attributed Medicaid beneficiaries that would support this discrete set of care navigation and additional activities to improve access. The provider requirements have been designed to reflect the unique role that family planning providers play in the healthcare system, and also to support coordination of care with other providers. Like I've said, provider requirements would align with the Primary Care Plus requirements where appropriate, but would also depart from them in certain important ways. Another note in terms of coordination with Primary Care Plus, providers will not be permitted to enroll in both Primary Care Plus and the FP APM. Providers will have to choose one or the other. However, and this is an important point, a PC Plus and an FP provider can receive a care navigation per member per month payment for the same Medicaid member, because those care navigation activities, one set for primary care providers, another for family planning providers, are designed to be complementary and to together support whole person care. So we're very much focused on ensuring, coordination and ensuring non-duplication, while also ensuring that there isn't any sort of, tension or fight between primary care providers and family planning providers over patients. The goal here, again, is to have everyone rowing in the same direction and supporting coordination of care and supporting whole person care for MaineCare members. Let me pause for a minute and just see if the OMS team has any feedback there.
Yeah, I just wanted to say that that's a really important distinction that we did receive a lot of comments on, is about whether a member could be attributed to both the family planning agency provider and the primary care provider. And I'm glad that you brought attention to that confirmation, because I think that's an important piece of the model that will help provide comments along those lines and feedback. Thank you.
Great. Thanks, Heather. Okay, so moving along here, we want to spend a little more time talking about the requirements in this proposed APM. Like I said, the provider requirements will align closely, but there are important distinctions. What you see here, we've just walked through each of the high-level requirements. It's really requirement category you can see here. And what we've done in the column to the right on this slide is show whether the requirement is the same as Primary Care Plus Tier 2, or whether there are some differences. And you'll see, in about a little more than half of the cases, they're the same. And in others, there are either some differences or they're not the same at all, again, reflecting the changes, the differences that family planning providers play compared to primary care providers. We've included in this set of materials, we've included all of the detailed requirements, both the original requirements and then the updates based on feedback that you shared with us from based on the original draft. Today, I'm only going to walk through some of the major changes that we've made, but they're in the materials here. We have all of the detailed requirements, again, both the original requirements and the new requirements based on the feedback. Okay, what you'll see on the next couple of slides just shows, again, on some of the major changes that we've made, shows the original requirement and then the updated requirements based on the feedback that we've incorporated. So the first item is on the HIE connection. So the original requirement was that family planning providers would need to maintain a participant agreement for data sharing with Maine statewide HIE based on really important feedback that we've gotten from you. We've changed that to maintain a view-only participant agreement with Maine statewide HIE. So that's the change on the HIE connection. Moving on to the care coordination capacity bucket, these are some small tweaks that we've made. We've been more specific about the rationale for what the coordination between family planning providers and other providers, what it's designed to do to support timely referrals and care navigation services. And we've made just a number of tweaks to the provider types where family planning providers would need to have a documented care coordination and referral relationship. The final piece here is the focus on interdisciplinary meetings with primary care providers. We had originally said that for members that are attributed to an FP provider and a primary care plus practice, that the FP provider would need to meet annually, either in person or virtually, with the primary care plus practice to talk about the member's health status and needs. Based on feedback that we got from family planning providers, that wasn't realistic and also sometimes wasn't necessary, given the reasons that members often seek care at a family planning provider. We changed it to participation in either an in-person or a virtual meeting with a primary care provider when requested, rather than it being something that's annual. Any other comments from the OMS team on these changes before I keep going? Okay. All right, so the next one is a big one that I want to focus on. In the original requirements, we were proposing to require that family planning providers deliver community-based community health worker services, and that was really aligned with some of the primary care plus requirements. We got a lot of feedback from family planning agencies that both the services that you provide are a bit different, and also the staffing roles and the care models are also different and don't always use community health workers. And so we've changed this requirement substantially. So it's now been retitled Community Outreach and Engagement, and it's much broader. So, conduct outreach and engagement in the community, to improve access to family planning services. And then we've been much broader and more flexible in terms of the type of individuals that could deliver that care, right? So staff with qualifications suited to the objectives of improving health equity. So this is really in direct response to the feedback that we received from family planning agencies that the original requirement was a little bit too narrowly tailored. Finally, on the continuous quality improvement piece, we've just changed it a bit. Rather than requiring an advisory committee activity, we're instead calling it patient experience feedback. And there's a requirement that Maine Care members be included in feedback processes, but not in the kind of more formal advisory activities that we had previously included. Any other feedback or comments on the OMS side before we keep going? Great. And as I've said here, in the materials, we've included an appendix with a full list of all of the provider requirements with all of the detailed changes for review and feedback. Okay, so now what we want to do is move from the requirements related to the family planning APM to what will drive attribution, which, as I've said before, is, I know, a really important concern. So again, to emphasize and to be really clear here, the driver of family planning APM attribution will be Section 30 rather than primary care claims. In other ways, this approach will look similar to primary care plus, but that's a really important distinction. So first, let's just talk a little bit about the 24-month look-back period. Members will be included in the attribution model if they received a Section 30 service from a participating MaineCare APM provider, a family planning provider, during the 24-month look-back period. And also either had full MaineCare or limited family planning benefit eligibility at the time that they received the Section 30 service. So it's not just full MaineCare eligibility. This also includes the limited family planning benefit eligibility as well. Like Primary Care Plus, there is a 6-month lag in that 24-month look-back period. In terms of how attribution would then work, attribution would occur quarterly based on claims data from the 24-month look-back period. Like I said, members would be attributed to the eligible provider where they receive the plurality of family planning services during that 24-month look-back period, and then attribution would be rerun every quarter. We've just included below a high-level timeline, a very illustrative timeline. Assuming a July 1st, 2024 program launch, which again is illustrative. For example, for the quarter starting July 1st, 2024, attribution would be based on the time period, the time period from January 1st, 2022 to December 31st, 2023. So there would be that 24-month look-back period with a 6-month lag. So that's the kind of general approach to attribution, similar to Primary Care Plus, but very different in that Section 30 rather than primary care claims will drive attribution.
Thanks. And Avi, I'll just jump in to say it another way too, like just to level set. So we are not on target for a July 1, 2024 start of this at all. That's not what this is meant to show. This is just meant to show if that were the start date, here's how those attribution periods, what they would look like. We're not talking about effective dates or start dates today. So really just to show you how that sequencing would look.
Great, thanks, Olivia. Appreciate you clarifying. Okay. So then we wanted to walk through a little bit more detail. I'm going to walk through some of the kind of estimates of member months, and then we'll turn it over to Maria to walk through the rate buildup. So in terms of estimated member months, we've included here, this is based on 2 years of historical data. You can see for MFP and for PPNNE, both what the estimated annual member months look like, looking forward to fiscal year 25, and then the average number of attributed members per month. I put this in the note, but I want to say it out loud as well. These estimates are directional and they're subject to change based on actual enrollment and utilization of services during the 24-month look-back period. And again, that will be, there's a 6-month lag to when the model actually starts. So this is a high-level estimate. It is certainly not something to sort of take as exactly what will occur, but we wanted to give some general directional sense of member months for each provider here. Okay, so I think you probably heard enough of me talking at this point. So let me turn it over to Maria, who's going to walk through more details around the rate buildup.
Great, thanks, Avi, and hello, everyone. I'm Maria Dominiak, and I'm an actuary working with the Maine team. I'm going to walk through the care navigation rate, PMPM, and then also the Medicare benchmarking analysis that we've done. And so as Avi mentioned, the first component is the care navigation per member per month cost. Assuming an effective date of July 1, 24, for purposes of modeling, that rate turned out to be $8.95 per member per month. And so this is an amount that you would receive every month for every person that is attributed based on the methodology that was described earlier. And to develop that rate, we looked at the Tier 2 Primary Care Plus rate because we felt that that was most well aligned with the family planning APM requirements, as Avi mentioned earlier. But then we made some specific adjustments for the differences in the requirements, either if they were in the places where we saw that there's new requirements that aren't part of that primary care plus rate, or slight differences. And we'll walk through those in a minute. And then as you all, I'm not sure if you all are aware, but the primary care plus rate really has two components to it. There's a base rate, and then there's an adjustment for the case mix, which meaning that the types of people that are attributed to primary care plus rate, there's an add-on, a population add-on payment in addition to the base rate to reflect the differences in needs for different populations, whether they're adults or children, or an age-blinded disabled population, or duals, whether they're generally well or complex. And so that component of the family of the primary care plus tier 2 rate is also part of our methodology as well, based on the attributed lives. And then the third step is to make adjustments for those differences in the PMPM. The things that we looked at in order to do that were the claims and eligibility data for Section 30, the provider surveys, which were very appreciative of the information that you all took time to provide, as well as Bureau of Labor Statistics wage and benefits information, trends to project the historical data forward using the CPI, Consumer Price Index trends, and also conducted a literature review and looked at some other states. So that's the overview. Next slide. So this slide shares the buildup of that step 2 and step 3 summary, where we started with the tier 2 PMPM base rate of $6.30. We made the population a risk adjustment PMPM and that is an additional $1.82. And that was really based on, again, the attributed lives in the modeling. So this is subject to change, but we looked at the population that was potentially attributed to the family planning providers based on whether they were children or adults or age-blind and disabled or duals, that status. And then we looked at the primary care plus allocations between what they call generally well or complex to determine that maybe 25% of the population of children were deemed complex, and therefore that methodology is what informed our population or risk adjustment PMPM. I think there's, again, this is all subject to your feedback. We could refine that methodology based on the actual attributed lives and run a risk adjustment model, or potentially lock that in. So right now we've assumed a static per member per month risk population add-on in this model. And that gets you to a total comparative rate in primary care plus of $8.12. In layering in the differences, that's an additional 83 cents. And we'll go into the next slide to share how we developed that 83 cents to get to the 893 or 895. So this slide summarizes the requirements and just those key requirements that are different. So anything that was the same in the previous chart between the Family Plus APM and the Primary Care Plus APM is no difference. And so these are just a summary of those requirements that might be a little different. For the health information exchange, even though there is a difference between data sharing and cost of view, in our survey with the vendor, they indicated there will not be any price difference. So we assume no difference in the PMPM for the data sharing versus cost of view. For the clinical capacity to deliver the same day screenings, that is a new requirement that's unique to the family planning APM. And so we took your provider survey information and then the assumed attributed member months that were used to develop this $2.14. And we do have more details in the appendix if you're interested in seeing how we derived each of these per member per month costs. For the same day access to all forms of contraception, similarly, we had information from the provider survey where you all indicated you have 3 full-time employees that are currently providing these services. And so we estimated an average salary, fringe, trended that forward, and also assumed that that the data that you provided is for across all the members that you're serving, not just Medicaid. So we adjusted that for the portion of Medicaid patients served. 30% is the assumption based on the information that you all provided that got us to the $1.24. For community health worker model, that, as Avi indicated, is a little different in terms of the requirements. And so that current per member per month cost in the primary care plus model, tier 2, is worth $4.20. So we removed that and instead substituted the new requirement around community outreach and engagement of $1.87. And that $1.87 is based on the survey. Again, information that you all provided, adjusted for the Medicaid portion of the patients served. And then the last component, there is a requirement in Primary Care Plus that requires the NCQA accreditation and some additional requirements for methadone assistance treatment costs. And that was worth about 22 cents. So we removed that from the Primary Care Plus tier 2 rate to get to the 83 cents total adjustment. I know that was a lot, but we do have a lot more details in the back. So the next section is the benchmarking that we did for the Section 30 rates. And so we assumed this the following policy in developing the Medicare benchmark rates. As Avi mentioned earlier, there's going to be a set of services that are considered the core set of codes for those family planning visit codes that will be benchmarked to 100% of Medicare. And so all of those codes are listed in the appendix. We've also shown you the Medicare benchmark rate that's current. So that's as of October 1 of 23. So Medicare will be updating those rates, and the rates will be for those services will be updated accordingly once this program is implemented. But wanted to share at least what we know today around what Medicare is paying for those services. You'll also notice in the schedules in the back, Medicare doesn't cover all of the services that are in this select set of codes. And so where that's the case, you'll see a 0. That doesn't mean that the rate is 0. It just means that there's not a corresponding Medicare benchmark, in which case we will be using the UCR fee schedule, the main care usual customary fee schedule, in that case where there is not a corresponding Medicare benchmark rate. For those services that you all provide on the Section 30 that aren't in that core set of services, those will be benchmarked to other main care fee schedules that are either right now 72.4% of current Medicare rates or existing UCR, Section 90, Section 55, Section 101 fee schedules. And so those will all be benchmarked to some existing either Medicare or main care UCR fee schedules. And I will turn it back over to Avi.
Great. Thanks, Maria. Okay, so the last building block here, we've talked through the care navigation PMPM and the Section 30 fee schedule base rates. In addition, participating family planning providers who meet or exceed certain quality benchmarks across a set of quality measures would be eligible for an approximately 55% fee schedule enhancement for Section 30 services that are eligible for the 90% FMAP. We've included here just some example measures that OMS is considering, but will be the sort of final set of measures would be developed with active stakeholder engagement in 2024. So this is just a menu of potential measures that OMS is considering. It is not at all this is not saying that all of these will be included. It's just a starting point for discussion. But you can see a set of measures focused on cervical cancer screening, chlamydia screening, set of measures focused on contraceptive care, and then some other, immunizations, SDOH screening, health-related social needs screening, et cetera. Again, just a starting point for a discussion, and there'll be a broader set of conversations, a more detailed set of conversations to discuss specific measures. In terms of kind of operational options for how this enhanced fee schedule payment could be made, there are really two options, and we invite feedback from providers on how to structure this. So one could be as, the providers would get paid out at the base rates that Maria just walked through. And then for those providers that meet quality targets, there would be an additional lump sum payment based on claims for dates of service that occurred during whatever the specified performance measurement period would be. So, it would be, you get paid at sort of the standard rate throughout the year, then OMS looks at quality performance over, a specific performance period, and for providers that meet the thresholds, then makes an additional payment, lump sum payment, based on whatever the percentage is above the fee schedule. Another option would be where you have a measurement period, and then if providers meet the measures, then prospectively for the next year or whatever the lag is, providers would receive an enhanced fee schedule rate as part of claims adjudication upfront, rather than there being a retrospective payment at year end. So different ways to structure this, and definitely invite feedback in terms of how to do that. Heather or others, anything you wanted to add there?
Yeah, I just wanted to add that, this is Heather from Office of MaineCare Services. Just wanted to add that emphasis on that there would be additional outreach in 2024 to make sure that we identify either from this list or additional measures that are going to be measurable and provide valuable feedback on the services that MaineCare members are receiving. And so this really is a starting point for that discussion. Thank you.
Great. Thanks, Heather. Okay, so what we wanted to do finally was to provide a very high-level financial analysis of the family planning APM. Again, this is using historical data, using historical sort of modeling what we think the attributed member months would look like. The actual dollars will depend on attribution at the point that the model goes live, and on utilization. All of that aside, to just give a sense of the high-level financial impact. The first row here shows the care coordination PMPM at $8.95 in aggregate, would be again around $760,000. The rebased fee-for-service payments would be around $1.9 million. Then the third piece would be the fee schedule quality enhancement, so the 55% rate increase on over and above base reimbursement for those services that are eligible for the 90% FMAP. And then there are a small amount of payments. Again, this is based on historical data that aren't on the Section 30 fee schedule. So when you add all of those up, it's about $3.4 million or so annually. Again, very high level and directional, but we wanted to give you some sense of how the different building blocks of the APM come together. Michelle, Olivia, Heather, anything you wanted to add either here or anything else before we start to move to comments and questions?
I'll just note that estimates are estimates, and we know that utilization changes, and so there are factors that pretty much always mean that estimates are precisely wrong, but they are directional. I'll give that caveat, and then I'll also note that we are anticipating that this fiscal is very similar to the currently projected fiscal for the current family planning add-on rate that is policy at the moment.
Great. Thanks very much. Okay, so let me turn it back over to Jessica to walk through some guidance on comments and questions as we move to that part of the discussion.
Right, thank you, Avi. So we're going to move to comments and questions. We ask that you use your raise your hand function, which is in the reactions for the participants controls. If you can, to leave time for everyone to be able to share their comments or questions, try to limit your discussion to around 3 minutes. Keep in mind that the chat, when you type things in the chat, we can't use that as the official post comment question that we respond to in writing. I will answer people's questions in the order that they raise their hands. If there's anybody who is on their, I think it's a tablet, they would use the Alt-Y on the keyboard to raise their hand. And if you're on the phone, please press *9 to call in or to raise your hand. And so we happy to take questions at this point.
And I'm going to stop sharing screen just so we can see each other, but I can pull any slides back up as needed.
Rhonda?
So we actually have 3 primary care clinics besides our 18 family planning clinics. So we would have to choose between PC Plus for those 3 clinics and doing this family planning one. Is that what you're saying?
Yeah, this model would allow for a member to have a family planning APM provider and a PC Plus provider, but each provider pay to group would have to determine, in other words, a provider group like Maine Family Planning or PPN&E would have to determine whether they were going to enroll as a provider of the family planning APM model, participate in that model, or participate in the PC Plus model. That's due to federal regulations around duplication of payment and things like that. Does that answer your question, Rhonda, or did you have a follow-up?
Nope, that was the way I thought I was understanding it. I just wanted to be clear.
Thank you. Feel free, anyone, to jump in, raise your hand. We're happy to answer any questions or provide any clarification.
Oh, thorough presentation, no questions. Maura?
Hi, thanks for this information. And in response to the question I put in the chat about the 2-week turnaround for feedback, thank you for considering that. I did see your reply, Heather. I'm wondering When will we have access to the appendices, I think, that were mentioned throughout the presentation, so we can have a little more detail to go off of, and also a copy of this presentation?
Mandy, what is the normal turnaround that we're able to post things at the website?
I should be able to post the presentation tonight. And if not tonight, then definitely by tomorrow morning it should be up.
That's great. And just to clarify, would it be just this recording, or will it be the slides? And then I think maybe I imagined it, but I think Avi referred to some appendices or something for more information, and I'm wondering if we'll have access to that as well.
The slides and the recording will be posted. I'm not sure about the appendices.
The appendices.
Oh.
Go ahead.
Oh, I was just going to say the appendices are part of the presentation, so those should be included as well.
Okay, there's more slides that we just didn't see.
There's more.
Oh, okay, okay, got it.
Yes,
got it.
And those include both more details on the provider requirements and on the rate buildup. Okay,
that's great, because I know in the feedback we submitted, there were a lot of questions about details for some of the requirements that, it's not answered yet. I know that's a lot of information, but hasn't been answered yet in the information we've seen. So I hope the provider requirement detail that you share with us will have maybe answer some more of those questions.
Yeah, and Avi, if you don't mind, let's just pop it up there and not go through every single one, but show the appendices right now.
Sure.
You'll know what they'll see later today or tomorrow morning.
Yeah, absolutely. I know. I don't want to leave too much suspense here. Hold on, let me.
And while Avi's bringing that up, I just wanted to mention I did post the link to the website where you'll be able to get the presentation and the recording, and that'll also be in the notice that goes out.
Okay, so just to give you a bit of an overview here. So what we first included is the draft fee schedule, Section 30 fee schedule. So that goes through, every procedure code and what the current, what the proposed rates would be. So that's the first piece, and it's the first few slides here. Then we have rate details related to the PMPM. And so that includes the rate build for each requirement. So for example, the same-day access to all forms of contraception, that goes through wage, fringe, trend, etc., and how we got to the rate that we did. So that's what we've done for every component of the rate buildup that is different than primary care plus. Maria, before I keep going, is there anything you wanted to add there in terms of the detail here?
Well, I did want to clarify on the Medicare fee schedule. It's just the codes that are the family planning, that core family planning visit code. So we didn't include everything because those will be benchmarked to other fee schedules. So these are just the 100% of Medicare codes that we've mentioned. And as I mentioned earlier, we've included the current rate and then the Medicare benchmark non-facility rate that it will be benchmarked to. It's just right now we just have October, so that rate obviously will change as the Medicare fee schedule gets updated. And then if you flip to some of the next slides, you'll see a lot of zeros in that last column. That means that it'll be the usual, the UCR fee schedule for those particular codes. And then as far as the PMPM rate details, where we had a methodology that incorporated number of FTEs, and you all provided that. We assumed some wages and fringe to develop that. In other cases, we might have just received a one total cost in the next slide, where we had the total cost, but not necessarily the additional FTEs to support that. And so, but this is the general methodology. And to the extent that we know that when you all were providing the data, the requirements, you provided data to support the requirements that now are different. And so we did try to make adjustments based on those new requirements, but we certainly welcome your feedback if there are some things that need to be refined in this methodology. We wanted to share at least how we were thinking about the approach.
Maura, do you have a follow-up question?
I do. Well, I guess just sort of clarifying that in the feedback we submitted in the past, we had raised questions about, or just asked for more information about what would meet the requirement for delivering same-day access to the full range of contraceptives. What does that entail from MaineCare's perspective? Or when it says to document the referral relationships, what kind of documentation would meet that requirement? Also, flagged concerns around the HIE connection and some of our carve-outs for patient privacy needs. So wondering, at what point can we or should we be having that conversation to dive into those details to assess the feasibility of this?
Sure. So I'm happy. Oh,
okay. I can actually provide some. This
Great.
is Heather from Office Maker Service. I can actually provide, I think, much of that clarification now, but please follow up with questions regarding the health information exchange connection. This would require only a view-only access, so you would not be required to report or supply any patient-level data to the health information exchange. It would just be to have a view-only access to be able to support care coordination. So that's, yes.
Just to clarify, because we use that term a lot, but when we say view only, does that mean that the family planning agencies will just be able to view what is in the health information exchange, or does that mean that others will be able to view their data? Because I know we use that terminology, but it's not necessarily clear.
Yes, thank you for that clarification, bringing that up. Yes, it just means that you would have access with this agreement to see patients' data where they've received, say, if you do a screening and you find that this person needs a referral for SUD treatment, you would be able to see if they're already receiving that or have received that in the past from other providers. So it supports you in providing care coordination services. So that's that requirement. I think your other question was around documentation of care coordination relationships, and we had discussed that in the past that that does not require MOUs or any of those contractual. It's something that you would have record of and be able to attest to as part of your application. And please remind me of what your third question area was, Maura, or follow up on any of those two.
What is the definition or the criteria for providing same-day access to the full range of contraceptives?
So that excludes sterilization services. And what that would mean is that if a patient, you have the capacity to deliver that. It's not about the service that day. It's about that you have the capacity on a daily basis to follow up and be able to provide same day access. So whether it be by telehealth or by, having the ability to dispense if we're talking, things those type of capacities, as opposed to the focus of the transaction service, which is covered by fee for service.
And will there be some sort of manual or attestation or something that will give that detail that you just shared, Heather? Or is there another place that we should look to for that kind of detail?
At this point, that is not developed, but that would definitely be part of a model that is fully developed and fully moving forward. Usually those requirements are part of a participation application. and where each provider attests to those capacities and and their ability to meet those requirements. And those would also be part of a provider manual for the model, like we have for PC Plus.
And then I guess I would flag, although, and then I'll stop because I'm sure others have questions or comments, but those are some of the details where I worry that at this stage, you know, we may say, yes, that does seem feasible, or that does not seem feasible. But then if the criteria or requirements for meeting these different requirements are more detailed or different from what we're already doing, then you know, it will be hard for us it'll slow down the process or make it hard for us to participate.
And thank you. Feel free to, you know, ask those questions or, you know, give those comments here today so that we can provide those clarifications about the requirements today.
I think most of them are already in the feedback that we submitted. So I think it's more so like the feedback that we submitted, just having some response to whether or not what we're currently doing would meet those requirements, or if something would need to be different would be helpful or reassuring for us in our understanding of this.
Yeah, and I can just say there, and Heather, you should jump in with more, any other follow-up, but you know, you'll see both in some of the changes that I walked through earlier and in some of these details that we have attempted to incorporate, you know, a significant portion of that feedback, you know, focused on, for example, on the HIE, on the community health worker requirement. There are a number of others as well. So we've certainly tried to incorporate that, but if there are areas where you feel like, you know, that still doesn't quite work, you know, you still want to see changes in X, Y, or Z ways, especially those that would have an impact on the rate on the PMPM, you know, please share that feedback, because it's certainly something that we're still looking for and are looking forward to, you know, incorporating into adjusting. But Heather, please jump in with anything else.
No, I'll jump in though. This is Olivia.
Thank you, Olivia.
So yes, I think this track changes attempt is to show you what the requirements look like as of today. You know, the collaborative process going forward will include a MaineCare rulemaking, you know, where you'll have the final time to look at the requirements, and there will have been much more conversation before we get to that point. But I think what Avi said was really important, because it's right now we're trying to get through essentially the rate setting process. If we make a decision in the future that impacts, even if it's, you know, past this comment period, if we make a decision in the future through a rulemaking or through further collaboration where we need to refine an input here or an expectation here, and that does impact the rates, then we will circle back and make that kind of adjustment at that time. So right now we think we've reflected the rates as the requirements are listed based on the information you provided and on other available information, comparable models, national sources, etc. If we end up being in a place in the future where something has become misaligned, then we are able to go back and revisit the rate again. All of this culminates at the time that we would get to when we would actually do a MaineCare rulemaking to, you know, in a state plan amendment to get federal approval to lock these things in. But that is, you know, not where we are right now, where we are trying to get through the initial rate setting process though.
I just wanted to make sure you were done. We do have a question in the chat from Brenda. Brenda, would you rather I read it, or I'm going to read it? Oh, go ahead, Brenda.
That's fine. Everyone can see it. I was just wondering if there is an estimate for the contribution percentage for each of the 3 payment components to the overall reimbursement.
Yeah, so on slide 24, we don't show the percentages, but we have all of the dollars. So that should be pretty straightforward. Let me just pull it up. So you can see here the total estimated reimbursement and then the contribution in terms of dollars of each component. So we haven't done the percentages, but the dollars are there.
So I did see that previously, and I apologize in advance because I know I'm very annoying to everyone, but that math just doesn't quite match what we have. So we'll, I guess, do a deeper dive, and then do you want us to sort of run that spreadsheet and then send it back as comments, or what is the formal procedure here to follow? Because we can't make that on slide 24, I think the 1.9 million number in the middle, we can't quite make that match up.
Yeah, so this is, you know, high level, and Olivia, you should jump into. This is taking 2022 utilization and repricing from sort of existing, you know, pre 225% add-on, you know, rebasing to 100% of Medicare, recognizing that your utilization now at the end of 2023 may look different than it did. You know, so this is really just a high level. I think you can get a sense on a percentage basis, you know, of what we're thinking when you look at each of these. But Olivia, you should jump in if there's more you want to share in terms of detail.
Yeah, and Brenda, sorry, where are you with? Who are you with?
I'm here with NNE, sorry, Planned Parenthood, NNE. I'm so used to just saying SRH providers, but technically here, I am here today with NNE. Thank you.
Okay, I wasn't sure if you were with a specific provider or across all providers, but also, Avi, correct me if I'm wrong, but this is all family planning. It's all family planning providers together. If you know, this is how this model would parse out for the universe. So yeah, any one agency would not be able to map those dollars to their own books.
Yeah, that's
but
right.
I think it was to try to say, okay, right now, you know, it's all coming fee for service. It's 100% goes fee for service. And you could think about the different fee schedules that you built MaineCare on. And then the future, a portion of it's fee for service, a portion of it's PMPM, a portion of it's quality add-on. So that was what we were trying to illustrate with those two things.
Yeah, that's right. It's an aggregate across providers.
Yep. So again, can I just ask about what's the process for communicating this back? So we took the NNE numbers that we know that we have internally based on their volumes. We did the rebase, we did this contribution, and the way it cut when I just did it was the fee for service rebase was closer to 20%. And here you have it as what, more like 55%, 60%. So there's something different about that. That's like very, very different. And so again, what process do you want us to use to communicate that back to you all?
So thank you, Brenda. The public comments form, you can make that analysis and provide that information and feedback to us. And again, there was correct me if I'm wrong, Avi, there was a really big difference between the fee for service reimbursement between different providers in the sense of their volume at different times and whatnot. So that may be where you're seeing that variance. And so, but yes, please feel free to provide your comments and any analysis supporting your comments through the public rate forum comment to the emails that you are provided on slide, I want to say 26, but I could be wrong.
Yeah, no, that's definitely right. And it's also very helpful for us because then we're able to take the data that you share and to align it with the numbers that we have to see where there are discrepancies, and then we can work those through. So absolutely.
Any more questions or comments? I want everybody to know Mandy did post the link to the presentation in the chat, so you can have access to that. if we wanted to give everybody enough time to make comments or questions, but we don't want to keep you if you're not, if we've answered everything, or you're going to compile your thoughts and address it in a written comment, that's great too. If we're all set, I think we have one more slide, Avi, and feel free, I'll give you one more chance before, when I'm done this slide, if you think of something else. I think it's 27. There we go.
Yep.
Yeah.
There we go.
We just wanted to remind everyone that the next thing coming due is comments to submit in writing. There was Maura's question, and we're going to discuss that after this call to see if an extension can be made to this date, and we will let you know. We do receive the comments after the deadline date, we will then review the comments, and then we do respond to them in writing, and then they get posted on the website. To ask general questions about this project, you can contact Heather Pelletier, and there's her email. If you have a written comment for this presentation or about this process, you can send that to my email or Jacqueline Smith's email. And then there's also a comments for the department will respond is that the MaineCare rate reform. What am I saying? Your comments and the department's responses will be posted on the website page, which I'd already said. Maura, go ahead.
So just to clarify, there won't be a feedback template or a survey that we should also fill out as part of this, or we can just use any template of our own design for feedback?
At this point, we would, there is no template or a survey.
Okay.
It would just be comments about this presentation.
Okay, yep, thank you.
And one last call for if anyone has any questions before we let you go. Oh, I'm not seeing any more hands. Does anyone from the department have anything to say, or Avi, before we jump off?
Not for me.
Thank you. Oh, go ahead, Avi.
No, I was just going to say not for me. Thank you.
Thank you, everyone. We really do appreciate your collaboration and engagement to work on refining this model, and thank you for your time today. We appreciate that you'll be providing comments, and we will be diligent to review them and respond. Thank you so much, and have a great day and a happy holiday.
Thanks, everybody.